Hello everyone. Thank you for joining us for the day 3 of the HDRN Canada Pragmatic Trials Training Program Conference. My name is Monali Malvankar, and I'm cross-appointed here with the Department of Epibiostats and Ophthalmology at Western University. We acknowledge that the Pragmatic Trials Training Program Coordinating Team's office is located in London, Ontario, around the traditional territories of Anishinaabe, Haudenosaunee, Nunavik, and Atharundran. These lands continues to be the home of diverse Indigenous people, First Nation, Métis, Inuit, whom we recognize as contemporary stewards of the land and vital contributors of our society. We also recognize that our work is carried out on the traditional territories of First Nation, Inuit, and Métis peoples from coast to coast, and we are thankful that we are able to work and collaborate on this land. This morning's conference presentations will run from 11:10 to 12:10. A quick lunch break from 12:10 to 12:55, followed by a noon presentation from 1 p.m. to 2 p.m. Agenda, speaker bios, and session links can all be found on the left-hand menu. To help you navigate today's event smoothly, here are some key housekeeping details. Reminder that the conference will be recorded. A copy will be sent to the attendees. Each session will begin with a presentation by one of our trial leaders, followed by a panel discussion and concluded with audience Q&A. If you have housekeeping questions throughout the day, please add them to the session Zoom chat. You can also privately message another attendee by navigating to the networking tab on the left-hand menu. Lobby chat will not be monitored, so please use the Zoom chat. During the audience Q&A, please feel free to raise your hand, hop off mute, or add your questions to the chat. Any questions we don't get to during the Q&A will be sent to the presenter. We also welcome your feedback on the presenter's protocol. Any feedback added to the chat will be passed along to the presenter. It's my pleasure to introduce Dr. Yan Zhu, an attending hematologist and thrombosis specialist at the Ottawa Hospital. Today, he will be presenting his trial, Pragmatic Randomized Investigation of AI in Symptomatic VTE Prevention. In short, PRISM VTE trial. Following the presentation, we will have a panel discussion featuring Gordon Fernie, Nicole Langlois, Stephen Kucher, and James Duquette. Please join me in welcoming Dr. Zhu, sorry.
Thanks very much, Dr. Malvankar, for the kind introduction. And I'm just going to share my slide. Fantastic. So good morning to everyone. And thank you very much for joining this morning on the discussion of this trial protocol for a pragmatic investigation of artificial intelligence in symptomatic venous thromboembolism prevention, or the PRISM VTE trial, which is a pragmatic cluster randomized trial. By way of introduction, venous thromboembolism is a group of conditions that includes deep vein thrombosis, which are blood clots that occur in the venous system, the veins of typically in the legs, and when they migrate to the lungs, they're known as pulmonary embolism. It is the third commonest cause of cardiovascular mortality after acute myocardial infarction or heart attacks or ischemic strokes. And in fact, each year, 45,000 Canadians are diagnosed with VTE. When we think about VTEs, we tend to think about the distribution of specific risk factors. About 20% of VTEs are associated with a transient major risk factor, such as surgery. Another 20% are associated with major persistent risk factors such as cancer or inflammatory bowel disease. And that leaves us with another about 50% or so that are unprovoked or transiently minor provoked risk factor. We recognize that medical hospitalization is a moderate risk factor for the development of venous thromboembolism. Now, when we think about in this diagram where in the x-axis we had the risk of symptomatic VT per patient year, and in the ascending fashion, the increasing risk of developing VT, we note that medical hospitalization, so admission to hospital for a condition other than VTE, is somewhat of a moderate risk factor for VTE. However, because medical hospitalizations are common, it is acknowledged that approximately 10 to 15% and up to about 20% of all VTEs are noted or diagnosed in the context of hospitalization for medical illness, either during hospital stay or within 90 days thereafter. Acknowledging this, the prevention of inpatient VTE is a key hospital quality metric that has been advocated since about 2 decades ago by Dr. Bill Gertz out of Sunnybrook, who wrote an editorial named Prevention of VTE a key patient quality metric, a key safety priority. And in 2011, Accreditation Canada has noted or included venous thromboembolism prophylaxis or assessment of VTE risk and appropriate use of preventative measures as a required organizational practice. So every hospital in Canada needs to have a robust plan in place to ensure that is taking place. And in some of the qualitative work that we've done so far, this has become the culture of inpatient medical care. Some of the quotes that we've heard include things like, culturally, everyone is on DVT prophylaxis here, and tons of healthcare dollars are spent on this, and for many patients, it provides no benefit and possibly harm. So is that so? Let's delve into some of the economic and environmental costs of VT prophylaxis before we delve into the medical evidence behind its use. In the table below, you can see the standard pricing based on the Ontario drug benefit price of the most commonly used form of DVT prevention agent, enoxaparin. And it's approximately $6.50 per dose. And these are administered generally daily for patients when they're admitted. In one of the cost effectiveness analysis that was done, it has been noted that approximately $43 are spent during each hospital stay to implement pharmacologic thromboprophylaxis or prevention strategies for VTE. And based on the number of admissions in Canada per year for the 3 commonest medical conditions, chronic obstructive pulmonary disease, so COPD, exacerbations, acute heart failure, and pneumonia, only for these 3 commonest admission diagnoses, approximately $8.6 million are spent on inpatient thromboprophylaxis, assuming that everyone is provided with pharmacologic prophylaxis. In addition to the economic costs, there are also environmental costs. The only approved source of production for low molecular heparins, which remains the standard of care for inpatient VT prevention through pharmacologic means, is through porcine mucosa, specifically the offals of pigs that are for which the intestines are subsequently made into low molecular heparins or unfractionated heparins. And it is estimated that approximately 1.1 billion pigs are used annually to meet global demand. Of course, the other components of the pig are used for commercial purposes, but there is still significant environmental cost in terms of separating the mucosa, the specific enzymatic decomposition, all the subsequent manufacturing practices that are associated with greenhouse gas emissions. So on the background of this economic as well as environmental costs associated with low molecular heparin use or heparin-based anticoagulant use or blood thinner use for VT prevention among medical inpatients, of course, one would assume that the evidence for its implementation must be robust. However, while there are 3 and several other large randomized controlled trials that have been completed, looking specifically through a placebo-controlled manner, the prevention of VTE among medical inpatients, it's important to recognize that these placebo-controlled trials have largely focused on screen-detected VTEs as primary endpoint. So meaning that every participant who had been enrolled in the trials were mandated to have a screening ultrasound, either at 6 to 14 days, and typically at 14 days or 21 days. And in this context, these trials have shown remarkable reduction in the incidence of venous thromboembolism, with relative risk, as you can see, ranging from the 0.37 to 0.53. However, it's important to recognize that screen-detected VTE, or specifically screen-detected deep vein thrombosis, or clots in the legs, can overestimate both the event risks, as you can see on the table to the right. The ratio of symptomatic DVT to, asymptomatic DVT that are screen detected to symptomatic events, which one would argue would be more patient-oriented and clinically relevant, ranges quite markedly, with a ratio of asymptomatic to symptomatic events in a setting of post-total knee replacement ranging between 15 to 21, meaning that a 15-fold higher risk of asymptomatic DVT is detected for every symptomatic event. And while not only does the detection or screening detected events overestimate the absolute risk of venous thromboembolism, there's also non-concordance of relative risk when it comes to interventions between those trials that looked at symptomatic events as endpoints and asymptomatic events as endpoints. This is work by Noel Chan, based out of McMaster, that has looked at the concordance between these two endpoints, with x-axis being the relative risk of intervention versus controls in VT prevention trials looking at asymptomatic events, and the y-axis being those looking at symptomatic events. If there's perfect concordance, we would expect that the relative risk would lie at the 45-degree dotted line. But you can see here, as shown, that there are many studies that have a reduction in asymptomatic screen-detected events, but have a higher relative risk of symptomatic events, and vice versa. Another limitation associated with contemporary studies to date is the fact that the intervention duration does not specifically reflect today's medical hospitalizations. In the seminal trials, the Medinox, Prevent, and Artemis trials, the specific duration of intervention, meaning thromboprophylaxis provision or use of blood thinner agents, ranged between 6 to 14 days, and that was mandated. Whereas if you look at medical hospitalizations of today, the length of stay is much shorter. And this is data from the Gemini group based out of Toronto that looked at some of the most prevalent conditions that are admitted to general internal medicine: pneumonia, heart failure, COPD that we talked about, where the median length of stay is notably lower than even the shortest duration of intervention for these trials, ranging between 4.5 days to 5.6 days. So what about some of the more recent evidence? Well, in 2023, the symptoms trial was the first trial that specifically did not use symptom screening detection for patients who are admitted for medical reasons, randomizing patients to enoxaparin 40 milligrams daily, which is the standard dose for medical prevention of VTE, to placebo. Patients were followed for a total of 90 days, and the primary efficacy endpoint was symptomatic VTE or fatal PE at 30 days, with safety endpoint being major bleeding at 30 days. To enrich the sample with patients who are at higher risk of potentially developing VTEs, patients over 70 years were included with anticipated length of stay over four days. So what did the investigators find? When they looked at symptomatic events, there is no statistically significant reduction in the primary endpoint of symptomatic VT or VT-related death at 30 days, with an absolute risk reduction of 0.4. But again, as you can see in the top, the confidence interval widely across is 0. And within specific subgroups, there is no specific subgroup that actually was noted to be statistically significant. Now, there are many caveats to this trial, including the fact that only about 70% of the expected event accrual had occurred before the trial had to be stopped early because of the onset of the COVID-19 pandemic and increased requirement for low molecular heparin for the treatment of COVID-19 infections, especially in the hospitalized setting. But nonetheless, gives us pause about the equipoise of routine provision of pharmacologic VT prevention methods that are, as noted before, ingrained in our medical culture. When we look at the incident VTE events on the left graph, with the y-axis being the incidence and x-axis being time since randomization, you can see that there's crossover, and that certainly in the first 7 days, there's no benefit to those who were randomized to enoxaparin, and there's no difference in major bleeding as well. So what do the guidelines say? Among acutely ill medical patients, the American Society of Hematology guidelines suggest the use of low-dose anticoagulation or blood thinners. However, this is a conditional recommendation based on low certainty in the evidence of effects. And they acknowledge that optimal strategies for VT assessment and decision-making on prophylaxis are yet to be identified. And further, that importantly, none of the existing validated risk assessment models for clinical use has undergone extensive impact analysis that shows their use leads to reduction in clinical outcomes. And similar recommendations or concerns about the role of risk assessment models have been raised in the American College of Chest Physicians, or the CHEST guidelines in 2012. So better risk assessment is needed. And in fact, when we think about the risk assessment models that have been developed to date, there has not been a model that specifically has been derived using a cohort of patients in whom none received thromboprophylaxis. They tend to be in a group of patients in whom some receive prophylaxis and some have not. And of course, the use of prophylaxis was accounted for in the derivation and validation of these risk assessment models, but there may be additional confounding by indication that have prompted a prescriber to prescribe VT prophylaxis when that may not be necessarily captured as one of the risk factors. And you can see here that in subsequent external validation of the 3 most commonly used risk assessment models, the Padua score, the IMPROVE score, and the Caprini score, the C statistics of these scores seem to be no better than age alone. And this is reflected in our clinical practice, where in the bottom graph, you see that the solid bars being those individuals, patients that are identified as being either high VT risk, as shown in the red, or green with low VT risk. And you see that there is wide variation across the different scores. And not only that, the prescribers tend to not only potentially underutilize VT prophylaxis or blood thinner medications among those who are high risk, but more importantly, seem to overprescribe VT prevention methods among those who are identified as low risk. And there is, again, variability across the score. So clinicians and prescribers may not even be certain about the validity of our existing models. So to summarize the need for a trial, VT is a preventable complication of medical hospitalization. Randomized trials that inform VT prevention in medical inpatients largely have used asymptomatically detected endpoints and may not necessarily reflect today's medical hospitalizations that have shorter length of stay. And trials, specifically the symptom trial, that use symptomatic events without screening detection have not demonstrated benefit to thromboprophylaxis. Pharmacologic prevention of VT in medical inpatients have enormous economic and environmental footprints, and that methods to identify hospital-acquired venous thromboembolism is needed to prevent events in hospital and post-discharge. So the objective of this PRISM VT trial then, with the primary objective, is to evaluate the non-inferiority of an artificial intelligence-guided thromboprophylaxis strategy on prevention of symptomatic VT among medical inpatients as compared to usual care, with secondary endpoints to look at the safety of AI-guided thromboprophylaxis on risk of bleeding, and the efficiency, meaning the proportion of pharmacologic thromboprophylaxis or anticoagulation blood thinners that are avoided using this strategy, and the cost effectiveness of this strategy compared to usual care. We plan a pragmatic probe, so prospective randomized open label masked endpoint step wedge cluster non-inferiority trial, with inclusion criteria of adults over 65 years being admitted with an acute medical illness with anticipated length of stay over 72 hours, which corresponds to the lower end of the interquartile range for length of stay that I had demonstrated using Gemini data earlier. Exclusion criteria are typical for inpatient prevention trials of VTE. Patients are admitted for planned procedure or reasons other than acute medical conditions, such as a procedure or caregiver respite. surgical indications for admission because these patients inherently have a different VT risk profile, or those who are admitted to a critical care unit for the same reason. Those with contraindication to low molecular heparin or unfractionated heparin, which are the mainstay of anticoagulant or blood thinner treatment for prevention of VTE, and those who are already on anticoagulants or blood thinners for an approved indication, such as atrial fibrillation, pre-existing venous thromboembolism, or mechanical heart valves. The intervention is AI-guided thromboprophylaxis, which we're planning to derive using machine learning models using existing data sets that include Symptoms 1, which is the trial that I had mentioned earlier, and data from Gemini, which includes 36 hospitals in Ontario with detailed inpatient laboratory imaging and clinical variables that have been collected. We plan to compare different machine learning models, including artificial neural networks, recurrent neural networks, those models that not only look at baseline data, baseline variables at the time when a patient is admitted to hospital, but their subsequent hospital stay in a dynamic fashion. Because for a patient who comes in with delirium, who improves and has improvement in mobility, may have a very different VT risk than someone who comes in for fully mobile and then subsequently has worsening deterioration that makes them more immobile, for example. Or there may be other variables that may change over time during hospitalization that can modify an individual's risk of acquiring VT during their hospital stay. And the model with the best evaluative characteristics will move forward, and we're completing a prescriber survey to specifically look at the MCID, or the minimally clinically important difference that prescribers are willing to accept in the increased risk of VTE to allow for a more tailored strategy. And certainly the sensitivity, meaning recall, or the negative predictive value will be an important aspect in looking at model selection, because certainly the last thing we want to do is inadvertently increase an individual's risk of developing VTE using our machine learning model. The comparison will be standard of care, and there may be several scenarios depending on the hospital that one practices at. Either the electronic medical record suggests a risk assessment model, it does not suggest a risk assessment model, and providers are asked to either opt in, meaning select an individual for provision of VT prophylaxis, or opt out, meaning that unless they specifically mention a contraindication such as active bleeding or an allergic reaction to heparins in the past, all patients are asked to be started on VT prophylaxis. Or in some centers, VT risk assessment or prophylaxis is actually not part of the electronic medical record. Incorporating a specific risk assessment model, such as the IMPROVE score, was considered, but because there is heterogeneity with respect to current practice in terms of the use of risk assessment model, and because of the limitations associated with risk assessment models to date, we elected for now to consider standard of care in its whole heterogeneity to reflect a more generalizable practice. So the primary endpoint is objectively confirmed symptomatic lower extremity DVT, or clots in the leg, and typically in the leg, or pulmonary embolism within 30 days of hospitalization. The definition of symptomatic means an event that requires treatment, such as anticoagulation or IVC filter insertion, or one that leads to death within 48 hours. And that's in line with the International Society on Thrombosis and Hemostasis, sort of the global International Society on Thrombosis Medicine's classification of pulmonary embolism-related death, where secondary endpoints including bleeding complications, use of thromboprophylaxis, all-cause of readmissions, all-cause mortality, and cost-effectiveness ratio. This being a pragmatic trial, we intend to ascertain outcomes using data that are available through routine clinical care. So for specifically when it comes to thrombotic endpoints in hospital, we'll be relying on data from the Gemini network, as I mentioned, which collects in a prospective fashion individuals who are admitted at around 36 hospitals in Ontario. And this data collection includes radiology reports, and they have developed a natural language processing-based detection algorithm for both deep vein thrombosis, and pulmonary embolism. This will be supplemented using diagnostic codes and transfusion and laboratory-based algorithm for detection of bleeding, as well as medication administration records to look at prophylaxis utilization. For post-discharge detection, we'll be relying on data from the ICS, including diagnostic codes from the discharge abstract datasets, database, as well as NACRS, the national, which captures emergency department visits, as well as OHIP database for those ambulatory office-based visits on the outpatient side. To supplement the data, we'll be also looking at Ontario Drug Benefits database to ensure that individuals who are diagnosed in the outpatient setting, in fact, are being treated in line with our outcome definition of symptomatic VT events. As I mentioned, on the inpatient setting, we'll be using natural language processing, which has far superior accuracy compared to ICD or diagnostic code-based algorithm. And this was a derivation and validation set that was done by the Gemini group showing excellent sensitivity and specificity with area under the curve or C statistics in excess of 0.95. On the outpatient side, we do acknowledge there are some limitations with respect to lower than expected positive predictive value. However, it's also important to recognize that the validation studies that underlie the ICD codes were a combination of both inpatient and outpatient setting, and that the positive predictive value being lower may be a reflection of the fact that some codes may be missed during a busy hospitalization stay, which is not going to be an issue in our pragmatic trial because they will be incorporated into natural language processing. And it's possible that in the outpatient setting where there are fewer competing diagnoses, that in fact, the sensitivity of the diagnostic algorithm using ICD-10 codes may be superior. And when used with imaging, that also improves the specificity. In terms of trial design, we elected to pursue a cluster randomized controlled trials instead of individual level RCT due to challenges that at the EMR level. The intention of the trial is based on prior literature that have looked at implementation of specific thromboprophylaxis practice, is that it has to be as easy as possible for prescribers to be able to implement it instead of having to go through a lengthy algorithm on paper. The availability of EMR means that a lot of the data can be included in a prospective fashion as a patient is being admitted and to automate the process of risk assessment. And in so doing, it is often challenging for electronic medical systems to incorporate both randomization as well as then corresponding in individuals' admission order sets to either standard of care or AI-derived algorithm. And that separating these two steps, such as having a prescriber obtain consent and then call someone for randomization, and then subsequently being alerted with respect to the randomization regimen, and then going back to the medical records to implement either AI-based or standard of care for thromboprophylaxis would simply be impracticable. There's also risk of contamination with respect to Hawthorne effect if prescribers are exposed to AI-derived recommendations and in fact may then shift their current clinical practice with respect to VT risk assessment. Whereas an individual who may have never used improved VT or other risk assessment model may start doing so in the standard of care setting because they're exposed to the fact that their patient is enrolled in the trial. And so the cluster randomized controlled trial, in our view, was likely the best way to mitigate some of this risk of contamination. Being a step wedge design, there will still be allocation concealment with respect to the allocation of timing of sites, at which point they transition from usual care or standard of care to AI-guided thromboprophylaxis, which will be concealed from coordinators, clinicians, and investigators until a month prior to that transition point. Additional design considerations include masking at the analysis stage. So the fact that we will be using ICS and natural language processing data will provide some additional safeguard with respect to masking, and will ensure that the analysts will be masked with respect to trial assignment. And to ensure that validity of our endpoint, we will perform trial emulation to establish the validity of outpatient VT ICD codes, as I mentioned, as well as inpatient VT natural language processing algorithm. We do intend on doing a subset of adjudication by masked adjudicators for those a select number of outcomes to ensure that the combination of NLP or ICD codes in combination with treatment do in fact align with adjudicator concordant outcomes. The sample size has yet to be finalized, but some of the parameters are included below. So the average admission duration of 5 days is typical for patients, and approximately based on current data, 40% of admitted inpatients will receive fungal prophylaxis. And based on prior trials, the ICC for appropriate VT prophylaxis is 0.01. We'll be likely starting with a pilot pragmatic cluster RCT to look at adherence and implementability. And this will also include adherence to look at the EMR audits of percentage of times when prophylaxis recommendations are overridden by prescribers. The type of analysis being a step wedge design will consist of a negative binomial mix model to analyze the effect of AI-guided prophylaxis on hospital-acquired VT incidents, and with intervention and control periods being modeled as a fixed effect, and then the clusters, the hospitals, being modeled as random effects with sensitivity analyses as shown. We do plan on having interim analyses at 25, 50, and 100% of accrued events, and a group sequential analysis. Ethical considerations are relevant here, as the AI-guided interventions are often, in some ways, a regulatory gray zone, especially those that target prescribers or healthcare providers. The minimal risk definition from TCPS would indicate that the probability and magnitude of possible harms implied by participation in the research are no greater than those encountered by participants in those aspects of their everyday life that relate to research. And it's important for us to recognize that anticoagulation stewardship, which includes appropriate provision of thromboprophylaxis prophylaxis or deprescribing of thromboprophylaxis prophylaxis, is already part of standard of care at many Canadian institutions, and I have included some of the quality of improvement work that's been done in British Columbia as an example. And it's important to also recognize ultimately the prescriber will decide about whether they concur or disagree with model recommendation. There are several ways in which we intend to address vulnerability in the ethics sense. With respect to frail individuals, we'll be capturing comorbidity burden through X-Howard Comorbidity Index to ensure that individuals who are enrolled in the trial who are frail are not at risk of developing additional complications than those who are less frail. And we'll discuss the ethnic and racially underrepresented populations through EDIA lens in the next slide. We consider the need for individual patient consent, and this is likely needed, though I would be interested in the group's consideration about when an intervention occurs at the level of the prescriber, and if the outcomes are collected at the level of the patient, whether consent needs to occur for participation or for data collection. An example that I raise here is that the ChartWatch, which is a quality improvement project that looked at early warning systems for medical inpatients. And in that study, the patient's consent was waived as part of a quality improvement initiative, although the notifications were made to the clinicians and subsequently acted upon. And there are also other cluster RCT of improved some risk assessment models that have been implemented in QI interventions, in which case waiver of consent was undertaken. However, it's important to recognize that if the intervention is, of course, occurring at the individual level, then an alternative consent model is likely needed, such as integrated consent or verbal consent, or an opt-out method, but I'd be interested in the group's thoughts on this part. And to wrap up, I like to emphasize the fact that there is marked underrepresentation of racialized population in venous thromboembolism research, and that there are data also to suggest that there are ethnic disparities in VT incidence and bleeding complications associated with treatment. And this may be a reflection of both genetic and ancestral diversity, but more importantly, also could relate to quality of care, such as detection biases, as well as the disease awareness. To ensure equitable participation or opportunity to participation among ethnic and racially underrepresented populations, we do intend to have print and video materials in collaboration with some of the work that's been done through the University of Bristol on the need for, or the rationale for participation in research that is multilingual in video formats, as you can see on the top, as well as making routine availability of virtual interpretation services for consent discussion. Finally, through use of some of the EMRs, such as EPIC, we are able to collect data on self-reported ethno-racial groups, and we'll be looking at that metric specifically to ensure that we are not inadvertently excluding ethno-racially underrepresented populations. And finally, we will have an advisory committee of patient partners, including those coming from underrepresented communities, community organizations, community health centers who interface with many individuals who are marginalized in the VT research community, and finally, policymakers. So thank you very much for your attention, and I look forward to our discussion.
Thank you, Yan. So now we'll transition into our discussion. We'll begin with the questions from the panelists, and then we'll open the floor to audience. So panelists, if you would like to briefly introduce yourself before your first question, that would be great.
Okay, I guess that's me. I'm Gordon Fernie. I work at the Ottawa Health Research Institute as a clinical research assistant, looking basically involved in subarachnoid hemorrhage or brain aneurysm research. But before that, back in Scotland, where my accent's from, I was a project manager in a multinational laboratory services company. And before that, I was a clinical trial manager in a clinical trial unit. And before that, I was a postdoctoral researcher and doing research in mental health and psychology. I've got a long research varied background. I don't have much clinical background in what I know about strokes, and what I know about thrombolysis is basically what you've just talked about. What an excellent presentation. What a brilliant summary of your research, your justification for it. I'm saddened to say to some extent that the preparation I did for this has kind of largely been answered in what you've talked about. So I'm kind of going to be going a little on the fly here with some of my questions. I wondered about you mentioned in your protocol that if the patient's risk of VTA changes over the course of the medical admission, that the AI will be able to change, or I wondered how it was going to link into the prescriber's decision tree. So is there going to be an update or live updating within whenever the prescriber's interacting with the electronic medical record to update that? And how is that going to work in practice?
Yeah, absolutely. And thank you very much, Gordon, that's an important question. Part of the implementation we'll be also looking at, the idea here is that often the decision about thromboprophylaxis is made at the time of admission. It's sort of that, admission sort of order sets, select the patient's appropriate diet, monitoring practices, vital sign frequency, et cetera. And then, VT prophylaxis is sort of that part of that initial admission decision-making. But often these decisions are not reviewed over time, and for patients who may have very lengthy length of stay in the hospital. So the intention here is that when there is a threshold, and we sort of set our threshold to be around 2%, based on the data from, again, trials such as symptom trial that looked at what is the risk of VT among patients who are universally anticoagulated for their VT prevention. So that's sort of the quote unquote best case scenario. And if we are able to identify patients in whom, that risk falls below 2%, because of their dynamic changes in their hospitalization, they're mobilizing better, they're working with physio and occupational therapists and so on, then the system would prompt the prescriber when they log in to reassess VT prevention in the same way that these same electronic medical systems would prompt individuals to review an ECG, for example, if it's done in a stat fashion, to say, hey, you ordered an ECG, please review it, it's been done. So that could be something that we could incorporate into the model. Of course, additional work, and this is part of that prescriber survey that we're doing, is assessing alarm fatigue, and there is that sort of fine balance between one day getting a notification saying, okay, start, and then the next day getting a notification saying, oh no, you should stop. So there's that balance between sort of frequency of notification and ensuring that we're prescribing VT prophylaxis in a optimal fashion that is intended to prevent patient-important outcomes. So to answer the question in short, really it's there is mechanism built in place in our existing electronic medical system. And more hospitals are moving towards Epic or sort of Epic derived EMRs, and so that is an advantage where when we develop the systems, that implementability will be maybe easier. But again, it potentially raises accessibility issues, especially for smaller hospitals. I hope that answers the question, Gordon.
Yeah, thank you.
I'm Nicole Langlois. I'm a research associate at the Ottawa Hospital Research Institute and also part-time manager of clinical research for CanVector, which is a national research network focused on VTE. So unlike Gordon, I do know a lot about VTE. And thank you, Jan, for highlighting a lot of the shortcomings of our past studies that have been done that are more exploratory or explanatory. And you talked about doing sort of some pilot work. And what are some of the biggest uncertainties that you'd like to look at? You did mention some, but I think there are probably a lot of uncertainties as you're moving to this model that we don't really see in the VTE space.
Absolutely. And thank you very much, Nicole, for your question. I think that, some of the, so, we talked about the implementability. I think that is the first and foremost question. Can we, ensure the timely transition of EMRs from sort of the standard of care to AI guided model? But more importantly, will there be enough prescriber buy-in? Is this an issue that people care about enough? The reality is that based on trials to date, and between different trials, there are sort of different effect estimates, but there's not a significant I mean, in some of the trials, there was a statistically significant increase in major bleeding, but overall, the risk of harm, apart from of course, patient-centered perspective, having to receive subcutaneous injections, economic standpoint and environmental standpoint, the risk of sort of quote-unquote clinical harm in terms of major bleeding is not significantly increase with the use of thromboprophylaxis based on some of the larger trials. Now, some of the trials did show there may be a small increase in risk of bleeding. So for some prescribers, perhaps they don't really want to go through the hassle of having to think about this question. They just want to be able to say, you know what, I'm just going to prescribe it and I'm going to forget about it. And I think that's some of the the prescriber survey that we're doing, as well as the implementability work needs to ensure that the model that we develop doesn't cause alarm fatigue. The model that we develop doesn't cause issues in terms of people just being sort of quote unquote fed up, being notified all the time about starting or stopping thromboprophylaxis. So that's the first piece. The second piece is that I think there is an increasing recognition of the importance of using routinely collected data when it comes to outcome ascertainment. But I think there is still some degree, I think, of discomfort with respect to validity as compared to sort of centrally adjudicated outcomes. And in some of the trials in the antithrombotic space, there is some degree of maybe overestimation of risks when looking at sort of investigator submitted events versus centrally adjudicated events. And so, you know, I think one of the important aspects is, of course, we're looking at patient important outcomes in that, you know, did this diagnosis of VT cause someone to go on anticoagulation? I think, in my view, I think that's, you know, a relatively patient important outcome because it resulted in a treatment that can potentially then subsequently increase someone's risk of bleeding. But, you know, how does that compare to centrally adjudicated outcomes? That's part of that implementability and the pilot work that needs to happen as well to convince prescribers that, in fact, we are capturing data in a robust fashion. And the third part of it, I think, you know, and there are, of course, many other aspects, is ensuring that, you know, that education piece of prescribers in that, you know, in some of the studies, you know, from our institution, one of my colleagues, Dr. Deb Siegel, has looked at small tubes for ICU-related phlebotomy, for example. It required a lot of education at the front lines to ensure that the clinical flow is not disrupted, that, you know, for example, in this trial, where we're maybe thinking about sort of that alternative consent model, that can be appropriately incorporated into practice when, you know, folks are overnight trying to admit patients that may have 20 admissions overnight. Does that flow work? Or do we need to think about alternative models? Those are sort of I think some of the questions that will need to be addressed at a practical level. I hope that answers your question, Nicole.
I'm not sure if I'm supposed to go now, Nicole, and we're doing one question at a time through the cycle, but thanks, John, for your wonderful presentation. It's added to the wonderful amount of diverse projects that are going on through this program. Myself, I'm located in Montreal, but I'm an epidemiologist doing my postdoctoral work through the clinical research unit at CHIO-RI in Ottawa. So again, thank you for this. I'm going to try and keep my question right now more methodological based, but since we've been talking about your AI tool, I'll go to my question kind of about that and add on to it. I think if I didn't misunderstand is that you haven't developed the AI tool. You plan to do it based on the data that's available. And I was curious how you chose one part, the 3% predicted or 2% predicted risk, I heard you say, and whether or not you think about how you can expand this tool beyond your settings that you choose, and does that mean that every kind of if someone wants to implement this intervention, they have to develop a tool that matches their data set? As you mentioned in your presentation, the problems with prediction tools and how they aren't always very generalizable.
Absolutely, and thank you, Stephen, for your question. I think part of it's a bit of a trade-off, I think, in some ways between having a data set of sort of symptomatic VT events in a placebo-controlled fashion, which is, you know, what the symptoms, the symptoms trial that was published last year provides. But, you know, there's also that sort of trade-off between, you know, and that trial was a trial in which it was an individual patient randomized control trial. And, you know, one could imagine that specific subgroups in whom VT rates could be considerable may have been excluded. For example, patients who lack capacity to consent and whom substitute decision maker cannot be reliably found. Among patients who are over 70 years of age, so if they come in with delirium that persists, and, you know, say, for example, if they live alone, that is you know, an important group of individuals who may be excluded. So there's that, you know, kind of tension between internal validity and generalizability and external validity, I think. The benefit of the Gemini data is that it does provide us with some, you know, ability to, because it includes 36 hospitals and counting in Ontario, to be able to have the robustness in terms of a sample size perspective. But, you know, to your point, Stephen, I agree with you. I think that, you know, it doesn't get past the issue of some of the criticisms of risk assessment models in which it was created in a mixed population in whom some people got prophylaxis, some didn't get prophylaxis, and beyond traditional risk factors. I mean, one could imagine that, as a prescriber, you see someone, ooh, like you're looking quite immobilized. That's not necessarily maybe captured in the database, right? And so that can be a challenge. My hope is that, using sort of machine learning techniques and looking specifically at dynamic changes during the course of hospital stay, that we'll be able to better tailor our thromboprophylaxis strategy. And hopefully overcome some of the confounding by indication biases that may be present. But again, I fully agree and acknowledge that there still may be a lot of data limitations. But I think the ability to look at things dynamically, of course, the intention is to only look at inpatient prophylaxis for now, but eventually, some of the trials that have looked at using some of these risk assessment models in the post-discharge VT prevention setting have been challenged. There are some reduction in VT rates, but again, increase in bleeding risks. So and again, that sort of determination of increased VT risks often happens at the admission level, at which point patients are randomized to either receive inpatient only or post-discharge, inpatient and post-discharge prevention. So, to summarize, I would say that hopefully our ability to look at things dynamically will provide us with additional important information that will tailor and refine our risk assessment models. But fully acknowledge the fact that confounding by indication remains a challenge. I hope that answered the question. Sorry, that was a bit of a long-winded answer.
Okay, my name is Jim Duquetis. I'm an internist and thrombosis physician at McMaster here in Hamilton. First off, I thought that was like a real master class in how to give a very clear, well-articulated presentation if there are other trainees in the online. Secondly, I have a couple of questions for Yan. And the first one is, can you articulate what is the main problem here? And the second one is, what is the question that you want to try to answer? And while you're thinking about that, if you'll permit me to give you a bit of perspective, or the audience some perspective, many years ago, very few people were getting prophylaxis in the hospital, and there were a number of trials that suggested that we should do prophylaxis with the limitations that Yan described. And then there was an adoption of a kind of immunization-based approach where everybody that comes into hospital is going to be at high enough risk that they all get prophylaxis. And then there were, clinical decision support tools developed because, some people were getting over prophylaxed, other people were getting under prophylaxed. But the problem there was that, people were too busy, as Yan alluded to take off all the boxes and identify who gets it and who doesn't get it. So I think there's a real opportunity for an AI-guided approach to do a lot of the work that clinicians traditionally were doing or not doing or don't want to do, that incorporates a lot of the factors that Yan alluded to kind of move the the needle forward. There's no pun intended there, by the way. And, in my view, as an internist, and I work in the hospital as well as doing thrombo stuff, it would be really nice if I could just, admit a patient. I don't have to worry about prophylaxis. An AI-based tool that incorporates risk factors takes care of that for me and is dynamic. So they stop it. And this has, to me, an opportunity that it provides a standard of care. So there's non-inferiority versus the usual care in terms of patient important outcomes like thrombosis and bleeding. But the added value is that it's superior because it saves costs, inconvenience for nurses, and so on and so on. So that's a bit of a background, and maybe I'll turn it back to you, Yan. And by the way, I did provide some comments to the proposal in the margins. I just don't have them with me. So thank you for that.
Well, thanks very much, Jim, and thank you very much for the comments in the background. I think those are crucial considerations, because I think ultimately, in my mind, the clinical question to be answered is, how do we identify patients who stand the most to benefit from thromboprophylaxis, in whom the risk of harm is, in whom, I guess, the net clinical benefit of thromboprophylaxis is in favor compared to usual care. And I think the reason why I sort of opted to consider usual care is the fact is, I don't know if sort of risk assessment models as they are currently, sort of derived and recommended are in routine use. And my sense is that, as you say, Jim, there's sort of this universal approach of like, just give it and then don't worry about it. And of course, coming from sort of an angle of better to have errors of commission than errors of omission in some ways. I think so. The clinical question really is, can we identify a group of patients in whom the net clinical benefit of thromboprophylaxis is greatest in order to mitigate the universal use of thromboprophylaxis? Because I think in some ways, it's hard to get below 2%, I think. It's sort of that, symptoms and other trials have seemed to suggest that from a symptomatic standpoint, even with universal thromboprophylaxis, we're looking at about 2%. And I think it may be the case that, of course, antithrombotics is not sort of 100% protective. And so and the reason why I elected to go with a non-inferiority approach is sort of along perhaps the same way as thinking about sort of pretest probability adapted, CT imaging for pulmonary embolism or for DVT diagnosis, where can we come up with a new strategy that saves on, in this case, thromboprophylaxis use without exposing patients to excess harm in the form of excess VTEs. So I suppose that's sort of the angle and perspective that came into this with, and which is why I sort of selected the primary endpoint to be VTE, because I guess to be able to sell this intervention to clinicians, one has to establish that it is actually safe. And so that's sort of the rationale. I don't know if that helped answer the question or not.
Can I go ahead or?
Sure. Is that okay? Yeah.
Yeah, I think you've identified what the problem is, and the problem is that we don't have a good strategy to identify patients who need and don't need prophylaxis. That's the problem. The all or none approach, we don't think that's useful. The improve or Padua scores, well, they're hard to implement. So that's the problem for a busy clinician admitting, like you said, 20 patients a day. And I think, to me, the question is more, can we improve on that efficiency so that we do administer prophylaxis to those individuals who probably would benefit, and don't to those who don't benefit, reduce, and in doing so, reduce the associated costs and inconvenience and potential harms. So, this is like an open discussion here. Everything's on the table, but I'd even consider making the primary outcome, errors of omission or commission, however you want to state that, versus usual care. I think that will have traction, because the traction will be important not just to the frontline clinician like me, but it will be for the anticoagulation stewards of the hospitals that say, hey, this approach reduces inappropriate use of prophylaxis. It saves the hospital money, and it decreases inconvenience to the patient and to the nurses and other people. That is, I think, an important outcome. You know, to have a non-inferiority trial that shows that, okay, you know, this approach doesn't have any benefit or doesn't, you know, harm patients from the standpoint of bleeding, to me is less important, because we already know that the baseline risks for bleeding in these patients are pretty low, like less than 1%. So I think you've got all the elements in place. It's just trying to, you know, what is the important facet of this problem that we want to address, and you know, that to me is really critical. And just to follow up on what others say, you know, of course, you know, doing a pilot trial is really important if you want to get. I mean, this is going to be a multi-million-dollar study easily. To get funding, you need some pilot data, and you've got all the other kind of ducks in the row, so to speak.
Thanks, Jim. I actually have a couple of questions / thoughts on that, but I see Stephen's hand is up.
Thanks. I also want to give the floor to Gordon and Nicole if they have any questions. I just have one that's kind of related to this in a sense. One of my questions is about, as I think Dr. Keddy has alluded to, is the choice of non-inferiority. And to me, I didn't fully grasp it, because I think a lot of your current setup, I know it's a preliminary protocol, it's not finalized, was kind of set up for the idea of, it was sold to me as superiority, as in this is going to improve things and reduce things. Whereas non-inferiority in my mind suggests that your intervention will keep things the same, but maybe you'll get some other benefits. For example, you mentioned costs. And so I guess I think, is your goal to have a patient meaningful improvement, and so a superior patient outcome, or is it to have a similar outcome at the clinic level, but have some sort of, I don't know, logistical benefits in terms of reducing costs to the healthcare hospital system?
No, I think those are important sort of considerations. I think, you know, perhaps what I'm sort of thinking about is, you know, I suppose maybe it's sort of the difference between the selection of primary endpoint and then how do we power the study. You know, I think just for example, you know, thinking about, you know, the studies that have looked at trying to reduce the number of, you know, CT imaging for pulmonary embolism, for example, you know, using different sort of modalities. And I suppose one worry that I have is that if we show that you know, this new algorithm is superior with respect to reducing, you know, the need for thromboprophylaxis, as an example. And if we don't power the study to actually make sure that patients aren't inadvertently getting VTEs because we're sort of reducing the amount of VT prophylaxis that's being used, I could foresee that maybe one criticism would be to say, well, you haven't proven that this is actually a safe intervention. Sure, it's, you know, seems like it's working, it's great for the environment, it's great for costs, but how do we make sure that in fact patients aren't being harmed using this approach? So perhaps, you know, and of course, just sort of throwing ideas out there, maybe the primary endpoint could be, you know, utilization rates, more of a sort of efficiency sort of outcome. But then the power calculation may still have to, you know, sort of still be anchored to an acceptable safety threshold, and safety not in the sense of necessarily of bleeding, but, you know, of VTE rates, to make sure that any reduction, if, you know, this strategy is implemented, isn't causing sort of downstream harm. I don't know if that sort of, does that resonate? Do you think that resonates or not really? Or
so for me, like when I think of non-inferiority, it's challenging because it doesn't necessarily improve power. It all depends on what your threshold is, and that becomes a kind of clinical question of who you're convincing of what your threshold is, and then you need basically a variance that basically does not capture that threshold. So I think your power situation doesn't necessarily improve by choosing non-inferiority. It depends on the situation, but I mean, I don't want to take this entire time to break this down. I'm happy to discuss this in future outside of this. But I don't think there's a solid non-inferiority benefit in terms of the power point of view. I think it just depends on what your question is and what perspective you come at it with. And you have to figure out which you prefer.
Makes sense. Yeah, I think, certainly it seems as though most NI trials, will require a larger sample size than, superiority trials. So definitely, for sure acknowledge that. I think part of it is just sort of, in my mind, is sort of how do we adequately power the trial in a way that it doesn't leave questions for sort of clinical, sort of prescribers to say, yeah, it seems all well and good, but unfortunately, I'm not confident that this intervention is actually going to not put my patients at harm. I suppose, maybe. Sorry, Jim, I see your hand is up there.
Well, no, I think this is a good discussion. I mean, the other way you could do it, yeah, I mean, this kind of involves maybe some grantsmanship now, is that I think you can sell it better that the AI tool will improve appropriate prophylaxis, and there's downstream effects. Now, okay, I get that you're concerned about safety. I mean, the powering may be based on the secondary outcome, which is to show that, your approach is not causing undue harm. So you may be able to do it that way, but I think, to me, if I'm reviewing a grant or I'm a clinician, it's more compelling to me that, oh, there's this new thing here that makes it easy for me, my life, and guess what? It reduces inappropriate. I mean, I wish we had something like that for, antibiotics, for overuse and underuse, all that kind of stuff. But it's the same kind of mindset that really moves the needle, as opposed to, oh, we're doing another non-inferiority trial. I don't know. That's just more a what is more compelling in terms of a grant application and for the people to be part of it and sign off on it. So.
No, for sure. Makes sense.
I have one other, I think, big question, as I know we're
Yeah,
taking up all the discussions.
Yes, sure. Go ahead.
And I think it relates to, I saw one of the questions in the chats. And to me, my question comes from your side of the step wedge. You mentioned, and I understand the benefits, I think, of why you chose a cluster trial. I wonder if you could expand a bit more about how you decided on a step wedge versus a parallel cluster trial, and how you got benefits from the step wedge versus just a parallel study design.
Yeah, for sure. I think, in some ways, part of it, I guess there are two components to it. I think first is, we want to leverage the fact that if this intervention sort of is, safe and, efficient / effective, we want to be able to roll this out at the end at all centers. So that's sort of the motivation number one. And then I think the motivation number two, and I see some, the questions in the comments about cluster sizes and, number of clusters. I do think that step wedge does provide a bit more, going back to the power discussion, a bit more of that statistical power compared to sort of parallel cluster RCTs. Now, fully acknowledging that there may be temporal related effects that can make step wedge trials challenging. COVID-19, for example, I'm sure, comes to mind in terms of, causing issues with respect to that kind of temporal aspect. But, those are, I suppose, in short, some of the considerations. One is hopefully we'll be able to implement this if this is safe across all participating centers at the end. And then two, leveraging a bit more power. I don't know if that resonates.
Excellent presentation, excellent discussion, and excellent questions from the panelists. So we do have some questions coming in our chat box, and I think some of them have been answered. We can go to the first one. So for the training model for the machine learning approach, will this be developed via using secondary admin data, for example, NACRS, via OHDP or physically captured charts at the local hospital?
Yeah, for sure. So I think there are two components, I think, in this sort of initial training work, is that one, we want to be able to, so there's an inpatient component, and then there's that sort of post-discharge component. For the inpatient component, we do have the benefit of the imaging reports that are available in. So I think that, definitely provides, sort of that granularity of data, as sort of demonstrated earlier with respect to better sort of discriminatory power from distinguishing, diagnoses that are coded eventually, and maybe it was ruled out PE that actually turned out to be not a PE, but then somehow gets coded as pulmonary embolism, for example. So I think from the inpatient side, that natural language processing based case identification is probably what we'll use. But we don't have the luxury of that, unfortunately, for post-discharge cases. And so, the intention is to look at things like NACRs, things like, DAD, things like OHIP, diagnostic codes. But from a, perspective, there's sometimes, issues with miscoding, right? Like a superficial vein clot versus a deep vein clot, for example. And so we do want to leverage the therapeutics data as well. And that's the benefit of, sort of that 65 plus population in whom most of by and large, all of the anticoagulants are covered through Ontario drug benefits. So we do have that benefit of being able to capture, in fact, yes, this patient had a diagnostic code, they had the imaging, and they were started on sort of that treatment dose anticoagulation. So you kind of get that 3 points together to ensure that it is a patient-important outcome. Often, we may not necessarily treat sort of deep vein clots below the knee, for example, in high-risk patients. And so, having that therapeutics data is also helpful. I hope that answers the question. Of course, happy to chat offline.
There's one more comment in the chat box. So non-inferiority trial generally requires a larger sample size than the superiority trial. And non-inferiority trial can also be converted to superiority trial, but not the other way around. So something to keep in.
For sure. And perhaps what we may end up doing, and of course, obviously it's sort of, again, as I said, sort of early in the stages, but perhaps what we could do is, if we accept the 2%, sort of quote unquote failure rate as being acceptable, I think some of the studies that have looked at, for example, diagnostic imaging, utilization and optimizing that, maybe we could just power the study so that we exclude the 95% confidence interval at 2%. That may be a strategy that we may be able to use, but of course, open to discussion. Sorry, Jim, I think I saw your hand up for a sec there.
Well, I put my hand up, then I lowered it because, I wasn't sure. You're just getting back to this issue of, is this approach considered safe for patient care? And I mean, we have a fair bit of data on, CD, clinical support tool based decisions in thromboprophylaxis that show that they're safe. So I'm not sure. I mean, I know if you want to make it non-inferior to usual care, you're going to need a fairly large sample size, and that will drive the overall sample size, and then you'll be able to show superiority and other outcomes pretty easily, I think. But I maybe you don't, your non-inferiority margin they don't have to be super tight, because the bleeds that occur are not that important. So rates of fatal bleeding from prophylaxis, for example, are very rare. So maybe what I'm getting at is kind of finding that sweet spot between answering the question and making it practicable and doable. We want to lower that sample size as much as we can, but have enough statistical power. So I just still think, if you can simplify care, and that's going to be a big step forward.
For sure, makes sense. Yeah, and
thank you.
Yeah.
Yes, Jan, maybe for more questions, you can You can put it in the chat box. We can pass on to Jan. A big thank you to everyone, and we reconvene at 1 p.m. for the next session. Thank you.
Thank you, everybody.
Well done, Jan.
Thanks again, Jan. Great job.
Well, thanks very much. No, thanks for all the questions.